Hello viewers, today we are here with Mr. Hari Subramaniam, the founder and director of Lifesigns, and he is going to tell about his journey and about his struggles. And I heard that he was also a three-time cancer survivor, so he will tell the real story about his journey so far. You tell about the journey what I asked you. Over to you, sir.
Hi, good evening. Thanks for having me with you. And I'm Hari Subramaniam, founder director Life Science. We are into remote patient monitoring. We started with monitoring patients in hospital first with the IoT devices. From there, today we have come to a point where we can monitor patients across the spectrum in hospital, in ambulance, and in at home. The full spectrum where the patient is picked up till he goes home, and even after he's going home, we monitor till he gets well. That's what we do today. And Life Science started in 2019, and during COVID, we commercially we were not able to go into hospitals much, but that part was the best part of the whole journey because we had so much of learnings during COVID, and in different hospitals we were able to look. We deployed our solution in various hospitals, and we started engaging with doctors and the clinicians to understand it better. And during that journey, we understand a lot of things, and we started implementing those feedback, the problem statements, the pain points, and what we saw the gap in the system. Because of this, today our solution is we were able to address the pain points, the gaps, and that's why in the short period of about 2 years, we are in about close to 120 hospitals across India, and we are in all kind of healthcare delivery institutions like private hospitals like Apollo or Aster or Kaveri. And we are able to validate in CMC kind of hospitals, AIMS, Bilaspur, PGI, and string of charitable hospitals in Kerala and Karnataka. We were also now in ESA hospitals, we were validated, railway health services, in few government hospitals in various states. So all spectrum of healthcare delivery, we were able to penetrate and give the best for them, which is, so our use case is different in each place. One, we started with critical care first, and we went on to do in ICU critical care areas. First we started with created step down ICUs in hospitals like HTU units, HTUs, step down ICUs, and pulmonology. From there we moved to now today we except pediatrics, rest all departments we have use case. And some hospitals we do the entire inpatient monitoring. In some hospitals like Apollo or Kaveri, we do the entire inpatient monitoring except pediatrics. Rest of the all patients are monitored by us. We have moved monitoring from a manual activity to completely a analog digital activity. We from our digital, because of digital monitoring, we were today, for example, some hospitals in our clients claim there is absolutely zero code blues in the hospital because of our solution, because our alert engine is very good, very robust alert engine we have. We have early warning scores in the dashboard. Because of this, because of zero code blues and readmissions into ICUs being reduced, the hospitals want the entire monitoring to be done by our solution, which means completely digital monitoring, which means every beat of the patient we monitor. So that's our USP, and we do continuous monitoring, uninterrupted, and stream data with a very few seconds latency to clinicians and doctors and hospitals across the board, so that the clinicians or doctors are able to get the best algorithm, so that the clinicians, hospitals, and doctors can go ahead, can see the data real time, and they can give their best solution to the patients. Apart from this, we also now today have a solution for ambulance, where we connect the ambulance seamlessly to the hospital, central monitoring, met or emergency triage. Before the patient arrives in the hospital will be prepared to do whatever to be done to the patient. And we are the only guys who connect the ambulance to the hospital real time continuously, giving the data with camera fitted, so that the doctor can also see the patient in the ambulance. We also giving a solution where the patient can go home after his discharge. He can go home with the biosensor and devices, so that he'll be still be monitored by the hospital. So which means the patient, from the time he's picked up till he's gone home, he'll always be monitored by the hospital. So he feels very safe. confident, and he can, any emergency, the hospital will take care.
Very insightful discussion, sir, and you have taken all the points what you are doing. So could you tell me about the key features of the ambulance, intelligence ambulance, what you do for the rural healthcare, and especially in emergencies, what you do? So about that.
See, we call our, say, ambulance, from earlier ambulance was, it was just mere a transportation vehicle where it takes the patient from point A to point B. From there are a lot of devices being fitted to the ambulance, making it a bit of a smart ambulance. Now, today, we are saying ours is an intelligent ambulance because with very few small form factor devices connected with our ambulance kit, the ambulance will be connected to the hospital real time, continuously, without interruptions, without blind spot. And our ambulance kit is so robust, versatile, that it can connect to the hospital wherever it is, and the data will be streamed to the hospital anytime, continuously, and without any blind spots. Plus, not stopping giving raw data, it also gives validated data, little analyzed data also. Alert engine mechanism works during the patient is in transport, and we also have the EWS score working, and the doctor will be able to see the patient real time in his screen in the hospital. That's why we call our ambulance as an intelligent ambulance, and our kit will look for a best signal. So our ambulance is also satellite ready. So the moment government opens the satellite communication, so which means even there is no mobile signal, our ambulance can communicate to the hospital screen, giving data continuously. That's why we call it as intelligent ambulance.
So you have latest collaboration with Railtel India. So what is the collaboration all about? Please shed some light upon this.
Yeah. So we feel, okay, hospitals in the city, they have access to new technology, and even new technology companies first reach the private hospitals or the top-notch hospital. But where technology and cost reduction is required very much is the rural India. To reach rural India, of course, we are a small company. We don't have that kind of bandwidth. Where Railtel was we were working with Railtel for quite some time, and Railtel was fair enough to partner with us in taking this technology to nook and corner of India. Railtel already has a network about 60,000 kilometers of network, broadband network laid across India, and their broadband strength and networking strength is very good. And we are very happy to partner with Railtel so that our technology can be used in rural India, where the same kind of clinical delivery we can bring it to rural India also. What a top-notch hospital in a city can do, the same thing we can bring it to hospitals in rural India, where the patient can go to a PHC. He will be monitored with the devices, our devices, with our software, with our solution. And the data can be seen by a doctor in a district hospital or a regional hospital or a district hospital, or wherever the skill set is available. A senior doctor can see and he gives his advice where that. So even the remotest part of India can get the same kind of care and medical knowledge which a city or a top-notch hospital can give. And our association with Railtel is we want to open 1,000 such clinics or patient care points across India in next 1,000 days.
That's great. So my last question is, today the era of digital AI and IoT and future is also on this thing. So what is your aspect about the healthcare, about the technology, use of technology? So are we using 100% of this technology, AI and robotics and all, or we have miles to go?
Okay. So, yeah, technology is a dynamic animal. So today, what it is today, because after a month it goes obsolete. But India, we need this kind of technology, and I think like how UPI we are today number one in the world. I feel we will leapfrog, jump the gun, and even healthcare, we will lead the race in the world, because a lot of IoT devices, new startups coming up with devices and solutions which the country like India needs. With the 1.4 billion population, when during COVID started, everybody was telling that our infrastructure is very poor or is less than the capacity. But today, with technology, with this technology, with the skills of our doctors, we will be able to reach nook and corner of India. Second, I feel the infrastructure spend is the major budget of a healthcare spend. Whether it's for the government or a person or individual, out of 100 rupees, the major part of it goes for the infrastructure and the critical care areas. If we are able to prevent before the patient becomes critical, then your infrastructure spend will go down, and the patient safety and patient also will be able to be back to his feet before he becomes critical. So which means prevention is possible, then we go spend more money on cure. So the technology will enable that we will spend less and prevent before things go south.
Thank you, sir. Thank you for talking with Medgate TV
Mhm.
Digital.